Put your hand on your knee right now. In the next 30 seconds, I am going to show you exactly where to press for how long and why it works, and you are going to feel a real difference before this video is even halfway done. No equipment. No waiting weeks for results. Just 30 seconds, starting right now, while I explain exactly what is happening underneath your fingers as you do it. Here is the move. Place 2 fingers just below your kneecap, on the inside edge, right where you can feel a small soft hollow next to the bone. Press firm enough that you feel pressure, not so hard that it sharply hurts, and hold steady for 30 seconds while breathing slowly. That is it. That is the technique. Do it right now if you are dealing with knee pain as you watch this, and keep watching, because what I am about to explain is going to change how you think about every flare-up you have going forward. While your fingers are pressing, here is exactly what is happening inside that joint. That spot you are pressing is the location of the infrapatellar fat pad, a structure sitting just beneath your kneecap that is packed with sensory nerve endings and, critically, is one of the most consistently overlooked sources of anterior knee pain in osteoarthritis. Research published in the journal Arthritis Research and Therapy has identified this fat pad as an active, hormonally and inflammatory signaling tissue, not simply cushioning, meaning it produces its own inflammatory cytokines that contribute directly to the pain signal you feel. And it is densely innervated with the same type of nerve fibers responsible for transmitting pain. Sustained manual pressure on this specific point works through a mechanism called counter-irritation, also known in pain science as diffuse noxious inhibitory control. When you apply firm, sustained pressure to a tissue, you activate large diameter sensory nerve fibers that travel to the spinal cord faster than the smaller fibers carrying your knee's pain signal. At the level of the dorsal horn of the spinal cord, same gate control mechanism we have discussed in previous videos on this channel regarding pain modulation. This faster signal essentially closes the gate on the slower pain signal trying to get through, producing a real, measurable reduction in the pain you consciously perceive within seconds to a couple of minutes. This is not a placebo effect. It is the same gate control mechanism that explains why rubbing a stubbed toe provides immediate relief, applied specifically and deliberately to one of the most pain-sensitive structures in the entire knee joint. 30 seconds is enough to trigger this gate control response and produce a noticeable, immediate reduction in pain intensity for many people. It is not, and I want to be completely honest with you about this, a cure. It does not regenerate cartilage. It does not reverse the structural changes of osteoarthritis. What it does is give you a genuinely fast, evidence-based tool for the moments when you need relief right now, before a walk, before getting up from a chair, during a flare that costs nothing and requires nothing except your own 2 fingers and 30 seconds. If that 30-second technique gave you even a small amount of relief just now, stay with me, because there is a second pressure point just as fast that targets a completely different pain mechanism in the knee, and using both together is more effective than either alone. Subscribe right now if you want the rest of this video and everything we publish on fast, evidence-based relief for knee arthritis, because what comes next builds directly on what you just felt. The second point is on the outer side of your knee, in the soft depression just below and slightly behind the bony bump on the outside of your shin bone, the area corresponding to the iliotibial band insertion, and the lateral joint line. Apply the same firm, sustained pressure here for 30 seconds. This location addresses a different contributor to knee osteoarthritis pain. Many people with knee arthritis develop secondary tightness and trigger point activity in the iliotibial band and the surrounding lateral structures as the body compensates for altered gait mechanics and joint loading patterns that develop once arthritis changes how weight is distributed through the joint. Pressing this point produces both the same gait control pain inhibition we just described and a degree of direct mechanical release of the compensatory muscular tension, which is why combining both points often produces a more complete sense of relief than either point alone. Let me show you a third point, because understanding the underlying pattern, not just memorizing 2 spots, is what lets you find effective pressure points anywhere you experience knee pain, rather than being limited to exactly these 2 locations. The general principle is this: any tissue that is a documented pain generator in knee osteoarthritis, meaning tissue that is densely innervated with pain-sensing nerve fibers, and that becomes mechanically or chemically irritated as part of the arthritis process, is a candidate for this counter-irritation technique. Beyond the infrapatellar fat pad and the iliotibial band insertion we have already covered, the pes anserinus, the conjoined tendon insertion on the inner side of your shin bone, just below the joint line, is a third common pain generator in knee osteoarthritis, particularly common in adults with a more inward knock-knee alignment pattern that places additional tensile stress on this tendon group. Pressing firmly here for 30 seconds using the identical technique we described for the first 2 points, addresses pain originating from this specific structure when it is the dominant contributor to your discomfort. How do you know which of these 3 points is most relevant for you specifically? The most reliable way is simply to try all 3 and pay attention to which one produces both the most tenderness when you press it, telling you that point is an active pain generator right now, and which one produces the most relief afterward, telling you that addressing that specific tissue is providing the most meaningful counter-irritation signal for your particular pain pattern. Most people with knee osteoarthritis will find that 1 or 2 of these 3 points are clearly more tender and more relieving than the third, and that pattern can actually provide useful information to bring to a physical therapist or physician about which structures around your knee are most actively contributing to your symptoms. Here's what I want you to actually understand about why this works, because the explanation matters more than the technique itself for your longer-term management. Osteoarthritis pain has at least 2 distinct components operating simultaneously. The nociceptive component, meaning the actual pain signals generated by inflamed tissue and irritated nerve endings inside and around the joint, and the centrally processed component, meaning how your spinal cord and brain interpret and amplify or dampen those signals based on factors including attention, anxiety, fatigue, and the kind of competing sensory input that techniques like this one provide. The 30-second pressure technique works entirely on that second component. It does not change what is happening structurally inside your joint, but it does change how intensely your nervous system is allowing you to perceive it in this exact moment, and that distinction is the difference between a genuinely useful, fast-acting tool and an empty promise. For lasting, structural improvement in knee osteoarthritis, the nociceptive component, the actual tissue-level inflammation and joint mechanics, is what the comprehensive program detailed throughout this channel addresses, the specific exercises that strengthen the muscles protecting your joint, the anti-inflammatory dietary changes, the proven supplementation, the appropriate topical and pharmacological treatments when needed. This 30-second technique is not a replacement for any of that. It is the fast, immediate relief companion tool that gets you through the moment, while the comprehensive approach does the slower work of actually improving the underlying joint health over the following weeks and months. I want to address directly why this 30-second technique is not something you have likely encountered from other sources, because the honest answer reflects something important about how health information typically gets created and distributed. Pressure point and counter-irritation techniques for joint pain sit in an awkward space within conventional medical communication. They are too simple and too low cost to be the subject of major pharmaceutical-funded research, since there is no product to sell from teaching someone where to press their own knee with their own fingers. And they are too specific and clinically detailed to typically appear in the kind of broad lifestyle content that dominates general wellness media. The actual underlying science, the gait control theory of pain, and the specific anatomy of knee pain generators we have described exists in legitimate, peer-reviewed pain science and orthopedic research, but the practical, actionable translation of that research into a specific, usable technique is something that requires someone to actually do the work of connecting basic science to a usable daily practice, which is precisely the gap this channel exists to fill. This also means I should be direct about what this technique cannot do, beyond what I already mentioned, because false modesty about limitations is just as unhelpful as overselling a simple technique. This will not meaningfully change your radiographic Kellgren-Lawrence grade. It will not regrow lost cartilage. It will not replace the genuine, structural benefit of the comprehensive strengthening and anti-inflammatory program, detailed throughout the rest of this channel, which works on a time scale of weeks and months rather than seconds, addressing the actual tissue-level disease process rather than your moment-to-moment perception of pain. What this technique offers is something narrower but genuinely valuable, a real, evidence-based way to reduce your conscious experience of pain right now, in this specific moment, using a documented neurological mechanism with zero cost, zero side effects, and zero waiting period. The neuroscience of why this gait control mechanism exists at all is worth understanding, because it explains why your body has this built-in pain modulation system in the first place rather than simply transmitting every pain signal at full, unmodified intensity. The dorsal horn of the spinal cord, where the gait control mechanism we have described physically operates, evolved as a filtering and prioritization system precisely because an organism that consciously experienced every single nociceptive signal at full intensity, with no capacity for the nervous system to modulate, suppress, or prioritize competing sensory information, would be functionally overwhelmed and unable to respond appropriately to genuinely urgent threats. The large diameter sensory fibers that counter irritation techniques activate are part of this same evolved prioritization system, and the reason firm pressure or rubbing produces real, measurable, neurologically documented pain relief is that you are using one part of an ancient, well-conserved sensory processing system to modulate another part of that same system, exactly as it was built to function. This is also why the effect, while real, is necessarily time-limited rather than permanent. The gate control inhibition you produce with 30 seconds of firm pressure typically persists for a period ranging from several minutes to, in some people, an hour or more after you stop applying pressure, but it does fade because the underlying nociceptive signal generation from the actual tissue pathology continues uninterrupted by this technique. This is precisely why I keep emphasizing that this is a tool for specific moments rather than a standalone treatment. You are not eliminating the source of pain. You are temporarily and repeatedly closing the gate that allows that pain signal through to your conscious awareness for exactly as long as you need the gate closed for a specific activity or a specific difficult moment. For the best results, combine this 30-second technique with the broader daily practices we have detailed extensively elsewhere on this channel. Performing this pressure point technique immediately before your daily strengthening exercises can make those exercises more comfortable and therefore easier to complete consistently, which matters because consistency, not intensity, is what produces the long-term structural benefit of any exercise program for knee osteoarthritis. Performing it before your daily walk, which we have detailed in a previous video as one of the most important things you can do for long-term knee health, removes one of the most common reasons people skip that walk on a higher pain day, the anticipation of discomfort during the first few minutes before the joint has warmed and the cartilage compression-decompression cycle has begun delivering its own natural, lubricating, and nourishing effect. This pairing with movement deserves specific emphasis because the combination produces a benefit that neither component achieves alone. The gate control relief from the pressure technique reduces the pain that might otherwise prevent you from beginning movement, while the movement itself then produces its own independent and longer-lasting anti-inflammatory and joint-nourishing benefit through the mechanisms we have detailed extensively in our daily walking video, the synovial fluid compression-decompression cycle that nourishes cartilage, and the muscle-derived interleukin-6 signaling that produces systemic anti-inflammatory effects. The pressure technique is, in this sense, most powerfully used not as an isolated relief strategy, but specifically as the enabling first step that makes the more structurally important activity of movement accessible on days when pain would otherwise be the barrier preventing it. This is the relationship between fast techniques like this one and the slower, structural interventions this channel focuses on most of the time. They are not competing approaches, and you do not have to choose one over the other. The fast technique removes the immediate barrier of pain that might otherwise prevent you from doing the slower work that actually improves your joint over time. Use both. Use this 30-second technique whenever you need it, as often as you need it, with no risk of overuse or dependency the way there can be with certain pharmaceutical pain relievers, and let it support, rather than replace, the comprehensive approach that produces lasting change. A brief but important safety note. This technique is appropriate for the common mechanical and inflammatory pain of osteoarthritis that we have described throughout this video. It is not appropriate as a substitute for medical evaluation if your knee pain is accompanied by significant swelling that develops suddenly, fever, redness and warmth spreading beyond the joint, or if the pain followed an acute injury or trauma. The same warning signs we have detailed in previous videos that distinguish a routine arthritis flare from a situation requiring prompt medical attention rather than self-management techniques. However evidence-based those techniques may be for the routine case. If this technique gave you real relief today, I want to know specifically what else you are dealing with, because that tells me exactly what to cover next on this channel. Are you also dealing with morning stiffness? Difficulty with stairs? A specific activity that triggers your worst flares? Tell me in the comments, because the most useful content this channel makes is built directly from what this community is actually experiencing, not from generic assumptions about what knee arthritis looks like for everyone. There is a fourth point worth knowing specifically for adults who experience pain predominantly at the back of the knee rather than the front or sides. We have focused on so far, since the popliteal region behind the knee has its own distinct pain generators that the three anterior and lateral points we have described do not address. The popliteus muscle and tendon, along with the posterior joint capsule, can become a significant source of discomfort, particularly in adults whose osteoarthritis has progressed to involve meaningful changes in knee flexion mechanics, and applying the same firm, sustained pressure technique to the soft tissue just below the crease at the back of the knee avoiding direct pressure on the visible blood vessels in this area, can provide the same gait control relief for this specific pain pattern. This point requires slightly more caution given the vascular structures in this region, and a gentler initial pressure, gradually increasing only as tolerated, is the appropriate approach here compared to the more straightforward application at the other 3 points. The question of how often you can safely use this technique throughout a single day deserves a direct answer, because I want you to feel confident using this as frequently as genuinely helps, rather than wondering if you are somehow overdoing a simple pressure technique. Unlike pharmaceutical interventions, where dosing frequency carries genuine biological constraints related to how the body metabolizes and clears a substance, manual pressure techniques like this one do not carry an equivalent buildup or toxicity concern. You can use any of these for points as many times throughout the day as you find helpful, before any activity that you anticipate will be uncomfortable, during any flare that develops, and as part of your regular routine alongside the exercises and movement practices we have detailed elsewhere on this channel. The only practical limit is your own skin and soft tissue tolerance to repeated firm pressure, which for most people allows for many repetitions throughout a day without any concern. The research foundation for gait control theory itself deserves brief additional context, because understanding that this is not a fringe or alternative medicine concept, but rather one of the most well-established frameworks in mainstream pain science, matters for your confidence in actually using this technique consistently. The gait control theory of pain was first formally proposed by Ronald Melzack and Patrick Wall in the 1960s, published in the journal Science, and has since become one of the foundational frameworks underlying modern pain medicine, explaining not only counter-irritation techniques like the one in this video, but also the mechanisms behind transcutaneous electrical nerve stimulation, certain acupuncture effects, and a range of other clinically accepted pain management approaches that all work, at least in part, through this same large fiber-mediated inhibition of pain signal transmission at the spinal cord level. This is mainstream, well-replicated pain science, not an unproven alternative therapy claim, and that distinction matters for how seriously you should take a technique this simple. For adults who find that pressing these points provides meaningful relief, a natural question is whether other forms of mechanical stimulation around the knee might provide similar or complementary benefit. And the honest answer is yes, through the same underlying gait control mechanism. A handheld massage tool, a tennis ball rolled gently around these same anatomical regions, or even consistent firm rubbing with your palm across the front and sides of the knee for 30 to 60 seconds, all activate the same large diameter sensory fibers and produce comparable, though sometimes slightly less targeted, relief compared to the specific point pressure technique we have detailed in this video. The specific points we have identified simply represent the locations where this general principle of counter-irritation produces the most concentrated and reliable effect, because they correspond to the specific anatomical structures most consistently implicated as pain generators in the knee osteoarthritis research literature, rather than being arbitrary or randomly selected locations. This video has given you something genuinely rare in health content, a technique that delivers on its promised timeline, an honest explanation of exactly why it works and exactly what it cannot do, and the scientific context to understand where this fits within both the broader pain science literature and the comprehensive arthritis management approach this channel has built across every other video we have published. You came here for 30 seconds of relief. I hope you got it, and I hope you are leaving with something more valuable than that. A genuine understanding of your own pain physiology that you can apply, adapt, and use confidently for as long as you are managing this condition. The relationship between this gait control technique and the broader concept of pain catastrophizing that we have discussed in previous videos on this channel deserves specific connection, because there is a meaningful psychological dimension to why this simple physical technique can produce benefit that extends beyond the pure neurological gait control mechanism we have detailed so far. When you actively do something specific and evidence-based in response to your pain, rather than passively experiencing it or simply waiting for it to pass, you are interrupting the catastrophizing thought pattern, the spiraling sense of helplessness, and amplified threat perception that research has consistently identified as one of the strongest predictors of how severely chronic pain is experienced, independent of the actual tissue pathology generating that pain. This psychological component does not diminish the legitimacy of the neurological gait control mechanism we have described as the primary driver of this technique's effect. But it does mean that part of why this works may be the simple, empowering act of having something concrete and immediate you can do, which itself reduces the anxiety and sense of helplessness that amplifies pain perception through the central nervous system pathways we have discussed extensively throughout this arthritis series. This is worth understanding because it means the benefit of having a reliable, fast-acting technique like this one extends beyond the 30 seconds of active gait control inhibition itself into the broader pattern of how you relate to and manage your arthritis day to day. Adults who feel they have concrete, evidence-based tools available to them when pain flares tend to experience less of the secondary anxiety and catastrophizing that can compound the primary pain experience. And this technique, used consistently and confidently, can become part of a broader sense of agency and control over a condition that can otherwise feel unpredictable and outside your influence. The specific timing strategy for using this technique throughout a typical day deserves practical, concrete guidance rather than simply telling you to use it whenever needed. Upon waking, before your first steps, applying pressure to whichever of the 4 points you have identified as most relevant for you, held for the full 30 seconds, addresses the morning stiffness and pain that we have discussed extensively in previous videos as the circadian peak of osteoarthritis symptoms, providing a head start on pain modulation before you place the first significant load on the joint after its least lubricated, least warm state following overnight rest. Before any planned activity that you know typically provokes knee discomfort, whether that is a flight of stairs, a longer walk, or simply standing to prepare a meal. Applying the technique 5 to 10 minutes beforehand allows the gait control effect to be active and providing maximum benefit during the activity itself, rather than only addressing pain after it has already become significant. During any unexpected flare, whenever it occurs throughout the day, the technique remains available as an immediate response, with no advanced planning required given how quickly it can be applied and how readily available your own fingers always are as the only equipment required. For adults managing knee osteoarthritis in both knees simultaneously, which is common given that osteoarthritis frequently, though not always, affects joints bilaterally, the technique can simply be applied to each knee in sequence, spending the full 30 seconds on each of the relevant points on one knee before moving to the equivalent points on the other side, rather than attempting to address both knees simultaneously, which most people find less comfortable and less effective than the sequential approach, given the hand positioning required for adequate sustained pressure. I also want to address a question that often arises once people experience genuine relief from a technique this simple. If this works, why have I never heard about it from my own physician or physical therapist? The honest answer is generally not that your healthcare providers are unaware of gait control theory or counter-irritation principles, since these are standard components of pain science education in medical and physical therapy training. Rather, the typical structure of a medical appointment, focused on diagnosis, medication management, and referral to appropriate specialists or imaging when indicated, often does not include the time or the specific framing needed to teach a patient a self-administered technique like this one, particularly when there are more pressing diagnostic or treatment planning priorities to address within a limited appointment window. This is precisely the gap that detailed, evidence-based health content like what this channel produces is positioned to fill: the practical, actionable translation of legitimate clinical science into specific, usable techniques that a typical medical appointment structure does not always have the bandwidth to provide, even when the underlying physician fully understands and would endorse the technique if specifically asked. This does not mean you should not ask your physician or physical therapist directly about this technique at your next appointment, and I would specifically encourage you to do so, both because they may have additional, personalized guidance about which specific points are most relevant given your particular pattern of knee involvement, and because physical therapists in particular often have additional manual therapy techniques and tools that can complement and extend what we have covered in this video, building on the same underlying gait control principle with techniques and equipment beyond what a self-administered finger pressure technique alone can provide. If this 30-second technique gave you real, immediate relief, hit the like button right now and subscribe, because we publish fast, evidence-based tools like this one specifically for people who need something that works today, not just information for someday. Share this with someone who needs 30 seconds of relief right now. And comment below, tell me whether you felt a difference, and which of the points helped more for you specifically, because that tells us which component of your knee pain is dominant and helps this whole community learn from each other's experience. Thank you so much for watching. See you in the next one.